Welcome back to the Deep Dive, where we transform stacks of sources, research, and technical documents into the essential knowledge you need to be truly well-informed.
And today we are tackling a huge topic, really a core subject for anyone in population health.
Public health surveillance and outbreak investigation.
Exactly.
Yeah?
And our mission here is to, transform these really complex systems of data monitoring into something practical and actionable. We want to trace the life cycle of health data.
Okay, so from symptom to policy.
Right. How does an unusual symptom reported by a single provider get collected, get analyzed, and eventually become the public health policy that protects millions of people?
And for the nurses listening, and we know there are a lot of you, this is not just theory. The source material really hammers this home. Surveillance is the absolute foundation of public health practice.
It is. It's not some niche thing for epidemiologists. This is a critical role for every single nurse working out in the community.
So if you're in a school, a clinic, a health department,
It touches everything you do. And in the real world, public health nurses are so often the first responders when things go sideways. They have to be ready for anything.
from just a routine disaster drill
To managing data flow in a huge incident command center. Their understanding of these systems, how to get quality data, how to see the patterns. That's what makes the difference between an isolated event and, a regional disaster.
it's how we figure out the timing, the geography.
And the people most at risk during a crisis. Think about the very beginning of the COVID-19 outbreak in 2020. That was all surveillance in action.
That idea of data quality is so important. But before we get into the technical side, let's step back. Surveillance, it sounds so modern, so tech-driven.
It's not. The roots go deep, centuries deep.
Really?
Oh, yeah. You can trace the basic concept of monitoring disease clusters all the way back to the 1200s,
What were they tracking?
the bubonic plague in Europe. People figured out pretty early on that systematic tracking was, well, the only way to even try to control something spreading that fast.
And here in the US, that idea actually became law.
It did. It's built right into the Constitution under what they call the state's reserved police powers.
Which sounds a little intense.
It does, but it's really just the powers that are necessary to preserve health, safety, and the general welfare. And this legal foundation gives health departments the authority to investigate unusual clusters of illness
So they can act immediately.
immediately, even if it means restricting some individual liberties for the greater public good. It's a very old concept with very modern implications.
And the nurse's role in this was defined early on, too. You see Florence Nightingale showing what a huge impact nurses can have, especially with data.
She was basically an early surveillance expert. Her systematic collection of mortality data during the Crimean War, how she presented it, it completely changed public health policy. She used data to drive action and save lives.
So bringing that history into the present day, let's get that solid, actionable definition. What exactly is disease surveillance?
Okay, so the definition is the ongoing systematic collection, analysis, interpretation, and dissemination of specific health data for use in public health.
A lot of keywords in there.
There are ongoing, systematic, and use. It's a continuous cycle. It never stops. And the end goal is always to reduce morbidity, which is illness, and mortality, which is death, to improve the health of the whole population.
It's applied epidemiology, really.
That's a perfect way to put it. Using that relationship between the agent, the host, and the environment to predict and to prevent.
So when surveillance first started, it was pretty much all about infectious diseases, right? Tracking the plague, smallpox.
Exactly. But today, the scope is just so much broader. It's kind of exploded because the threats we face have evolved.
So it's not just about germs anymore.
No. I mean, infectious disease is still critical, of course, but modern systems also monitor chronic diseases like diabetes and heart disease. They track injuries, environmental and occupational exposures.
Like a chemical spill or something.
Right. Or pollution from a factory. And it even goes into personal health behaviors, like smoking rates or nutritional habits in a specific community. It's a really comprehensive health information network.
With a net that wide, you must have to classify the data you're collecting very carefully.
You do. And this is a really crucial distinction for knowing if what you're doing is actually working. We collect two types, process data and outcome data.
Okay, what's the difference?
So process data is all about what is done. It's the protocols, the services you provide, the effort you put in.
It's like how many people you reach.
Exactly. A great example is a big flu shot campaign. The process data would be the proportion of the eligible population that actually got the vaccine. It measures your effort.
Okay, that makes sense. So the outcome data must be.
The impact of that effort. Outcome data focuses on the change in health status.
Ah, so did the flu shots actually work?
Precisely. For that same example, the outcome data would be the incidence rates, the number of new cases of influenza in that same population that year. You have to analyze both.
Because if you vaccinated a ton of people, but the flu rate didn't change.
Then you know something is wrong with your program. Maybe the vaccine wasn't a good match, or your delivery method needs a serious reevaluation. It feeds right back into quality improvement for nurses.
And this need for rapid, effective surveillance just gets magnified when you think about acute threats, especially the ones that are human-made.
Absolutely. Public health preparedness means we have to understand the two major forms of intentional crises. The first one is bioterrorism,
And that is.
the intentional use of microorganisms, so bacteria, viruses, or toxins from living things to cause widespread death and disease. The things that come to mind are agents like botulism or anthrax. They're designed for mass casualties and panic.
And the second type isn't biological.
Right, that's chemical terrorism. This is the intentional release of hazardous chemicals, maybe into a water system or as an aerosol. Things like the nerve agent sarin or a toxin like ricin.
All right. Here's a thought that I think gets to the heart of why surveillance is so important. The source says that controlling these agents without baseline data would be almost impossible. Why is that? Why can't you just treat people as they show up sick?
Because of how weird the attack would look.
Yeah.
I mean, if a really rare disease like anthrax just pops up out of nowhere, or you see this sudden surge of symptoms that look like a chemical exposure, you have to be able to compare that pattern to the usual
The
pattern.
baseline.
The baseline. If the endemic rate, the normal rate for botulism in your county is 0, and you suddenly get 10 cases, that's the red flag. That deviation tells you it's either a freak natural outbreak or maybe an attack.
And if you're not constantly collecting data,
You have no baseline to measure against. You lose hours, maybe even days, in your response time. And with these agents, that's catastrophic.
that comparison, knowing what's normal so you can spot the abnormal, is everything. So let's look at how we use this system. What are the key features of a quality surveillance system?
Okay, you can really group the features into 3 big principles. First, mandatory planning. It has to be organized. It can't be random. Second, continuous action. It's ongoing data collection, regular analysis. It never stops.
And the third.
Necessary dissemination. This is huge. You have to share the results. You have to communicate with the public. And that sharing has to lead to actual public health action, reducing illness, improving health.
So it's a mandatory, continuous feedback loop.
That's a great way to think about it.
And what are the main purposes of that loop? How does it serve the public?
Well, the purposes are vast. It helps us assess the public health status of a community. It lets us respond immediately to weird disease spread, like with Zika or a big foodborne outbreak. It helps us set priorities, plan programs, evaluate them, and like we said, establish those critical baseline rates.
Let's connect this to the bigger picture. How does all this link back to the 3 core functions of public health? Assessment, policy development, and assurance.
Okay, let's use a real-world example, something that's not an infectious disease. Let's say pediatric obesity in a school district.
Right.
So, for assessment, the surveillance data tells you the magnitude of the problem. What's the prevalence of obesity? Where is it concentrated geographically? Is it getting worse over time?
So you're defining the problem with data.
Right. Then that data feeds policy development. If the data shows a huge problem, you can use it to justify and develop new clinical protocols for school-based health clinics, maybe new rules about physical activity or the food being served.
And then assurance is checking if the policy works.
Exactly. Assurance is closing the loop.
Yeah.
You keep monitoring the data to see if your new protocols are actually effective. You compare the obesity rates before the program with the rates after. That's how you assure the community that the services are making a difference.
That's a great example. To handle something that complex, though, from obesity to bioterrorism, you must need a ton of partners.
A massive network. And it has to ignore all the usual jurisdictional boundaries. You need federal agencies like the CDC, state and local health departments, hospitals, labs.
But it's even broader than that, isn't it?
Oh, much broader. You need medical examiners, veterinarians, because so many diseases jump from animals to humans, law enforcement, 911 dispatch, poison control centers, even international groups like the WHO for a global event.
With that many different players, how do you coordinate a response? You can't just call a committee meeting when something happens.
You can't. And that's where algorithms are so important.
Like a computer program.
Sort of. Think of it more like a precise step-by-step plan. A playbook. For nurses, these are invaluable because they standardize the response. The algorithm tells you which events to investigate, who to call right away, how to share the information, and most importantly, who is responsible for taking action.
It takes the chaos out of the first few hours.
It's the standardized playbook for a crisis.
Okay, let's drill down into the nurse's role specifically. The Quad Council Coalition outlines these core competencies for public health nurses. How does surveillance fit in?
It fits into several of them all at once. Let's use a scenario to make it real. Imagine a public health nurse in a big city clinic. She starts to notice a pattern of weird, non-specific respiratory illness in kids from one particular neighborhood.
Okay, so a potential cluster, what's the first competency that kicks in?
Assessment and analytical skills.
Mm.
Right away. The nurse has to define the problem. Is this just a normal flu spike, or is it something else?
She has to figure out the cause.
Exactly. And identify data sources. Where do these kids live? Where do they go to school? She's looking for risks in the community. Maybe it's air quality. Maybe it's something in the housing. He's using evidence to make decisions.
So once her assessment suggests this is a real, unusual cluster, she has to help organize the response.
Right, which brings in policy development and program planning skills. She's participating in planning the immediate response. That could mean developing a protocol for rapid testing or working with the school to set new attendance policies. She's helping shape the immediate strategy.
And in a crisis like that, communication is everything.
Which is the next competency. Communication. And this is often the hardest part. The nurse has to present accurate information to all kinds of different audiences.
Worried parents, the media.
The health director, other clinicians, and she has to make sure everyone understands, regardless of their literacy level. This is a huge patient safety issue. Miscommunication during a crisis is a risk factor all by itself.
And she can't do this alone in her clinic.
No way. That's community dimensions of practice. She has to connect with the schools, local pediatricians, community leaders. She's collaborating with partners to really define the boundaries of the problem.
And finally, she needs to know what the latest science says.
Yeah, basic public health science skills. She needs to be able to find the current evidence-based practice for whatever this is. If it's a new virus, she needs the latest guidelines. She has to know who's responsible for what, contact tracing versus environmental testing, to make sure the response is coordinated.
This whole systematic approach, it really mirrors the nursing process itself.
It maps onto it perfectly. The source has a great table showing how the nursing process aligns with emergency preparedness.
So how does that work?
Well, the assessment phase is about identifying populations with special needs in a disaster. So, older adults, people with mobility issues, people on oxygen.
People who will need extra help.
Right. Then the planning phase is developing specific care plans for them. How do we evacuate them? Where do they go?
Implementation is putting the plan into action.
It's the drills, the training, the exercises. You have to practice the plan. And evaluation is checking if it worked. Did the special needs shelter evacuation protocol actually function?
And the goal of all of this is?
To assure capacity. To make sure the community can actually respond effectively and equitably when an emergency hits.
There's also the Minnesota model, which gives nurses a kind of roadmap for surveillance as an intervention.
It's a really practical 7-step guide. It starts with asking, is surveillance even the right tool for this problem? Then it moves to organizing your knowledge, setting clear case criteria, collecting enough data, analyzing it, and then interpreting and sharing the findings.
The last step is evaluation.
Right. Evaluating the system itself. Was it fast enough? Did we miss cases? Was it worth the cost?
This brings up a really complex point. Ethics. I mean, surveillance, by its very nature, often means collecting data without every single person's informed consent, especially in a crisis.
It's a huge ethical minefield, absolutely. There was a systematic review by Klinger and colleagues that just blew this wide open. They found this massive gap in clear ethics guidance.
And they found a shocking number of issues, right?
An incredible number. 86 distinct ethical issues that could pop up during surveillance, especially around informed consent.
86. Wow. Just trying to imagine a nurse navigating that during an outbreak. That's a lot.
It is. So, that research led to the development of a comprehensive ethics matrix. It documents specific conditions where it might be justifiable to forego traditional informed consent, always balancing individual privacy with the public safety. It provides nurses with evidence-based ethical guidelines for those impossible situations.
So let's shift to the raw material here, the data itself. Where does all this information actually come from?
It's flowing from everywhere, all the time. from frontline clinicians, from hospitals, from labs. They all report cases to state health departments. We also get it from official documents like death certificates, medical examiner reports, even hospital billing records.
And we can break that down into two big categories, right? Mortality and morbidity data.
We can. And mortality data, the data about deaths, is uniquely valuable for long-term planning.
Why is that?
Because things like vital statistics reports are often the only source of reliable, long-term health data for small geographic areas. It lets epidemiologists see persistent health differences between groups, track preventable deaths, and plan programs to meet big national goals, like the ones in Healthy People 2030.
So mortality data tells us where we're failing in the long run.
In a way, yes.
Uh.
And the other side of the coin is morbidity data, which is about illness and injury.
And that's a much broader category.
Much broader. It includes notifiable disease reports, special cancer registries, injury surveillance systems, all sorts of things. It gives you the real-time picture of what's happening, whereas mortality data is more of the historical record.
With all these systems in place, it feels like we should have perfect data, but we know we have problems with underreporting.
It's a huge systemic problem.
Yeah.
And it's rooted in some very human, practical issues.
Like what?
Well, social stigma is a big one. For diseases like HIV or STIs, people might avoid getting diagnosed, or clinicians might be reluctant to report.
And I imagine doctors are just busy.
Exactly. They're overwhelmed. They might not even know about a specific reporting requirement, or just a low priority compared to the patient in front of them. Plus, in some areas, you might have limited diagnostic ability.
So we need to standardize things as much as possible to overcome those hurdles.
We do, and that was a major problem before 1990. States were all using different criteria to define the same diseases, so you couldn't compare the data. It was a mess.
What changed?
In 1990, the CDC and the Council of State and Territorial Epidemiologists, the CSTE, got together and created the first list of standard case definitions.
Everyone started using the same rulebook.
Exactly. And that created the National Notifiable Disease Surveillance System, or NNDSS.
And that's the system that requires states to report certain diseases to the CDC. That data becomes the Morbidity and Mortality Weekly Report, the MMWR.
Which is basically the Bible for public health professionals.
What kind of diseases are on that national list?
It's anything that poses a major public health threat. You've got the scary, low-incidence things like anthrax, but also more common but highly transmissible diseases like measles, Lyme disease, tuberculosis, and newer threats like Zika.
But there's a catch, right? The reporting is mandated by state law, not federal.
That's right. So not every single nationally notifiable disease is legally required for reporting in every single state. But for the data that is required, it's now transmitted electronically through the National Electronic Disease Surveillance System, or NEDSS.
That's the digital backbone.
Right. It makes the data uniform, simple, and most importantly, fast.
Let's really focus on the tool that makes this all work. The case definition. Why is it so vital?
Because it's the heart of standardization. It provides a uniform method that takes all the guesswork out of it. It spells out the exact criteria, clinical symptoms, lab values, maybe even epidemiologic link, like exposure to a confirmed case.
And you can't always have 100% confirmation. So how are cases classified?
They're classified based on the strength of the evidence. A case can be suspected, probable, or confirmed.
So a suspected case might have the right symptoms, but no lab test yet.
Exactly. A confirmed case has all the boxes checked.
And for a nurse, this is really important because you can't wait for every lab result before you take action.
Absolutely not. This is a critical point. The case definition is for reporting. It should not be the only thing you use for clinical diagnosis or for starting a public health intervention. You have to act the moment you suspect a problem, even if you can't officially call it a confirmed case yet.
Can you give us a concrete example of a case definition?
Sure, let's use hepatitis A. The clinical case definition requires a clear onset of symptoms like fatigue, abdominal pain plus jaundice, or high liver enzymes. But to be a confirmed case for surveillance, the patient also needs either a positive IgM antibody test or they need that epidemiologic link, say, they shared food with a known case. That precision is for reporting. A public health nurse would start contact tracing on a probable or even just a suspected case long before that final lab result comes back.
The whole system is really powered by technology and informatics now, and there are 4 distinct types of surveillance systems that we use.
Right. We classify them as passive, active, Sentinel, and special systems. They're basically different ways of getting the information.
So let's start with the most common one, the passive system.
A passive system is when we rely on case reports being sent in voluntarily. So doctors, labs, hospitals, they send their reports to the local health department. It's the routine, day-to-day background noise of surveillance.
So a nurse might use this to do a community assessment.
Exactly. They might pull data from the state's reportable disease system for something like the MAPP process.
But the big criticism of passive surveillance is that it's slow.
It is slow. You're relying on busy people to take the time to report. Its major weakness is that an outbreak can be well underway before the reports start trickling in. But we rely on it because it gives us that continuous, cost-effective baseline data for a lot of common diseases.
Okay, so that brings us to the active system. This sounds like the opposite.
It is. The difference is initiative. In an active system, health department employees, and this is a classic public health nursing role, they actively go out and search for cases.
They're hunting for the data.
They are. They're calling providers, visiting hospitals, specifically to figure out the magnitude of a problem they already know or suspect is there.
Can you give an example of a nurse doing this?
Absolutely. Let's say a nurse finds out about one confirmed case of multi-drug-resistant TB in a homeless shelter. That's a huge red flag.
So she's not going to wait for more reports to come in?
No way. She launches an active surveillance campaign. She goes to the shelter, she interviews people, she contacts the local free clinics, she calls the hospitals and asks, have you seen any unconfirmed TB cases lately? She's trying to find every single exposed person to stop the spread. It's intense, but it's vital.
Okay, next up is the Sentinel system. This sounds more targeted.
It is. A Sentinel system uses a small, pre-selected sample of providers or agencies, the Sentinels, who agree to report on a specific health problem.
And what's that useful for?
It's great for monitoring common diseases and making projections. Like for the flu season,
How does that work?
you might have a few key clinics or ERs across a state designated as Sentinel sites. They report every week on how many influenza-like illnesses they're seeing. By tracking that small, reliable sample, epidemiologists can project how bad the flu season is going to be for the whole state.
So hospitals can prepare.
Right. And it's also used to estimate disease rates in vulnerable populations where it's hard to get good data, like with undocumented workers.
And finally, we have special systems.
These are often developed for specific threats, like bioterrorism. And the most important development here is what we call syndromic surveillance.
That sounds complicated.
The idea is pretty simple. It uses automated data systems to monitor illness syndromes. So
Yeah.
groups of symptoms, like fever and cough, or vomiting and diarrhea, in real time.
So it's not waiting for a specific diagnosis.
Exactly. And the system that does this on a national scale is the National Syndromic Surveillance Program, or NSSP. It pulls data directly from ERs, urgent care centers, even from pharmacy sales of things like flu medicine. It gives you a super early warning sign of a potential outbreak.
We saw how important that was during the pandemic.
Hugely important. But it's been used for other things too. It was used to detect clusters of carbon monoxide poisoning after hurricanes. The system saw a spike in people reporting headaches and dizziness in areas without power.
So public health could warn people about using generators indoors.
Immediately. It's all about speed and spotting those unusual patterns before they become a full-blown crisis.
Okay, so surveillance detects the problem. Investigation is what you do next. When does a problem warrant a full investigation?
An investigation is warranted for any unusual increase in disease or any unusual event, and the amount of effort you put in depends on the threat.
So 5 cases of the common flu is no big deal.
Low effort. But 5 cases of a rare, lethal chemical poisoning, that's maximum effort. All hands on deck.
And what are the main goals of that investigation?
It's a 3-step process, really. First, control and prevention. Stop the spread. Stop people from dying. That's immediate.
Okay.
Second, identify contributing factors. Figure out why it happened. What was the agent? Who was the host? What was going on in the environment?
And third?
Implement prevention. Use what you learned to make sure that exact thing doesn't happen again.
Before you can even start, you have to define the scale of the problem. And epidemiology has very specific terms for this.
Right, and it all starts with understanding the baseline, which we call endemic. That's the usual persistent level of disease. It's what you expect to see.
Like foodborne botulism in Alaska.
Exactly, that's endemic there. Yeah. But if that baseline is always really high, we call it hyperendemic. If cases pop up irregularly, that's sporadic.
And when things get worse than the baseline?
That's an epidemic or an outbreak. The number of cases is clearly in excess of what's expected.
And if that spreads globally?
That's a pandemic like COVID-19.
Mm.
And there's one more, holoendemic, which is when a disease is super common in childhood, so people build immunity and the prevalence actually goes down as people get older.
So once you've defined the magnitude, you need a plan. The CDC has a very clear step-by-step process for an investigation.
It's the algorithm in action, a linear process for efficiency.
What's step one?
Confirm the outbreak. Is this a real increase or just a reporting error? Then verify the diagnosis and define the case. Use that standard case definition.
Then you figure out how big it is.
Right. Estimate the number of cases. Then you orient the data to person, place, and time. Who got sick, where did they get sick, and when.
The classic epidemiology trifecta.
It is. That helps you develop and test a hypothesis. Maybe it was contaminated water at the park. You test that idea. And finally, you institute control measures and communicate your findings.
That orientation, step, person, place, time, that's what helps you see the patterns of occurrence.
Exactly. It helps you figure out the source. Is it a common source where everyone was exposed to one thing, like a gas leak?
Or a point source.
Which is the type of common source, but the exposure was brief and everyone got sick at once. Like the bad potato salad at the one-hour church picnic.
Then you have a mixed outbreak.
That's where it starts from a common source, but then it starts spreading from person to person.
And if the source is around for a while?
That's an intermittent or continuous source, like contaminated food sold at a grocery store over a couple of weeks. And finally, a propagated outbreak is just pure person-to-person spread, like tuberculosis. It spreads slowly over time.
And all of these outbreaks come down to the interaction of the epidemiologic triangle: agent, host, and environment.
Oh.
Let's look at the agent. How do you classify its potential to cause harm?
There are three key measures. First is infectivity.
Ah.
How easily can the agent get into a host and cause an infection?
Second is pathogenicity.
That's the proportion of infected people who actually get sick and show symptoms.
And third, virulence.
That's the measure of severity. Of the people who get sick, what proportion become severely ill or die? Measles is highly infectious and pathogenic. The common cold is infectious but not very virulent.
And what are some of those host and environmental factors that play a role?
Well, host factors are things about the person, their age, their immune status, their genetics, their lifestyle choices. Environmental factors are the physical surroundings, the weather, sanitation, access to clean water, crowding. A virulent agent in a crowded, unsanitary environment with a vulnerable host. That's the recipe for a disaster.
We have to come back to the threat of covert bioterrorism. What are the really unusual red flags that an investigator has to look for?
These are the signs that something is just not right, that it's not a natural event. A huge number of sick people with a similar weird syndrome, higher death rates than you'd expect, a common disease that doesn't respond to the usual treatment.
Or a really rare disease just showing up?
A single case of a rare strain of plague, for example, or a disease with a weird geographic or seasonal pattern, like a severe respiratory virus peaking in the middle of summer, or even seeing lots of dead animals right before people start getting sick. These are the cues that demand an immediate, high-level response.
So this whole cycle surveillance investigation, it all feeds into the main goal, which is prevention. How does a nurse use the 3 levels of prevention in a major health event like the COVID-19 pandemic?
COVID is a perfect framework for this. So primary prevention is what you do to stop the disease before it even starts.
Like vaccines and masks.
Exactly.
Right.
Mass screening and vaccination programs to reduce the occurrence. That's primary.
Then secondary prevention is about early detection.
Right. It's about stopping the spread. This is the heart of surveillance and investigation. It's actively investigating a cluster of illness in a school, doing contact tracing, and using quarantine to stop the disease from propagating.
And tertiary prevention is for people who are already sick.
It is. It's focused on reducing the long-term damage, providing high-quality health care and treatment for people who are already infected. It includes rehab for long-haul symptoms, for example.
In the most severe situations, like a pandemic or a bioterror attack, the government might have to implement really extreme public health measures.
They can. They can invoke those police powers we talked about. That can mean mandatory quarantine, which is for healthy people who are exposed, and isolation for people who are actually sick.
And closing public places, restricting travel.
Even seizing property or mandating vaccination. These are severe measures for severe situations.
And what is the nurse's role when things get that restrictive?
It is absolutely crucial. Nurses are on the front lines, administering care, enforcing these measures, managing decontamination. They have to be experts in using standard precautions like PPE and hand hygiene to protect themselves and to stop from becoming vectors for more spread. The whole system is designed to make sure we can do this effectively and ethically when we have to.
This has been a really deep look into the engine room of community health. We've seen that public health surveillance is so much more than just collecting data.
It's a systematic, data-driven cycle: collection, analysis, interpretation, and then action. It's how we manage everything from the normal endemic baseline all the way up to a global pandemic.
And for you, the future public health professional, what are the key practice takeaways?
I think there are a few clear ones. Surveillance gives you indispensable knowledge about disease patterns. It helps you evaluate your programs by giving you that crucial before and after data, and it demands continuous learning and tech skills. Your ability to synthesize all this data and collaborate is what protects the public's health.
So, to leave you with a final provocative thought, building on those ethical complexities we talked about, we discussed the ethics matrix and the challenge of informed consent. As technology keeps advancing, with systems like the NSSP that can pull data automatically from ERs and pharmacies in near real time, how can public health nurses make sure that the speed and efficiency of that data collection still prioritizes an individual's right to privacy while also maintaining the safety of the entire population?
That is the question, isn't it? It forces us to reconcile this rapid-fire technology with centuries of ethical thinking, and the answer will really define the future of population health nursing.
Indeed. Thank you so much for joining us for this deep dive into public health surveillance and outbreak investigation. A warm thank you from the Deep Dive team.